This is a lecture. This is the lecture I gave on low dose naltrexone to AMMG about 2 weeks ago. You know, we have our conflicts, and we're okay there. One of the fun things is that they have to you have to declare what is off label, and so you all understand that this whole lecture is off label. So
Bill, I have a question, Bill. If
Right.
it was off-label, did you get the CME credit for it?
Yeah, they got it approved.
How is it that if it is off-label, if it is not an experimental basis, how can you get the CME
credit? You know what? I don't know. They got it, and I'm actually in the process of getting. So I've recorded all of these, and I'm actually getting in the process of.
I got those Dollar Tree.
Can I get somebody to be a co-host here, Dr. Halasa, if you're here, so so we can get all that. I'm really not sure, but I'm working on getting these. I've recorded these all on video, and then I have a transcript and the slides, and I have the AOAs actually looking at them to grant CME credits for the course, and this is part of it, and they seem to accept it. So I don't know. Okay, so our objectives would be, I guess I don't need really because what is naltrexone? What is low dose naltrexone? Mechanisms of action, conditions known to be treated successfully with low dose naltrexone, efficacy, safety, how is it dosed? What are the most common side effects and contraindications? And then we'll go through some herbal and homeopathic remedies that actually enhance or mimic it. Okay, so 1980, let's go back, 1985, New York City AIDS crisis. Their patients started showing up with all sorts of kinds of crazy infections, cytomegalovirus, meningitis, pneumocystis carinii, pneumonias, just all sorts of crazy things. And the etiology was, determined to be a virus, and we didn't have any of these antivirals now, and so it was sort of kind of anything goes, and there was a lot of there was a lot of death, and there was a sort of desperate times called for desperate measures, and I never did figure out how it was a Dr. Bahari, this guy number 2, he was like the main driver of this, how he figured out to take naltrexone, which is a medication which had only been released in 1984 for opioid blockade, and to reduce it by 90% down to 10% of its prescription dose, and that somehow it created endorphin release and increased inflammatory or controlled inflammatory cytokines. So, so the AIDS patients exhibited compromised immune system, and their endorphin levels were 1/3 of the normal endorphin volume, and opioid receptors were found present in many immune cells. Messenger RNA, there's a word we hear lately, inside the immune cells code for endorphin receptors, and something called toll-like receptors or inflammatory cytokines also have an affinity for opioid receptors. So the opioid system and opioid receptor system is where immune cells are significantly inhibited by morphine in a dose-dependent manner. Interferon alpha and interferon beta production by normal lymphocytes and fibroblasts are also inhibited by morphine, and the inhibition of the interferon alpha production by morphine is reversed by opioid receptor antagonists. And so that's what naltrexone is. Naltrexone is an opioid receptor antagonist. There's 4 types of major opioid receptors: delta, kappa, mu, and nociception receptors. The mu is the main one. They're present pretty much all over the body, but especially in the brain, the spinal cord, peripheral neurons, digestive tract, and the immune system. And remember that 80% of the immune system resides in the small intestine. And keep that in mind when we start going through the lower dose naltrexones, that its capacity to take care of many different types of entities, which seems improbable, is because of the opioid receptors are found all throughout the body. So endorphins are endogenous opioids. They act as immune modulators. When we block the opioid receptors, the body gets fooled into thinking that it needs to produce more pleasure receptors, more endorphins to overcome the block to affect the pleasure. And that's actually one of the first mechanisms of action for this. So opioid growth factors, medenkephalin 5, and opioid growth factor and growth factor receptors have pain modulation properties, and they regulate the immune function and cell proliferation. Opioid growth factor and growth factor receptors suppress autoimmune reactions, decrease inflammation, they decrease interferon gamma and TNF alpha, and they have antibacterial, antifungal, antiviral properties, and they slow the growth of malignant cells. And the reason I bring this up is because these are all the areas that naltrexone, especially in the lower doses, operates against. So naltrexone was, like I said, 50 milligrams was approved. It also comes as 100 in 1984 as an opioid receptor antagonist. It was used to treat alcohol and opioid dependence. There was no agonist properties to naltrexone. It permanently suppresses microglial cell expression and permanently disrupts opioid growth factor receptor axis. And the reason I say permanently, because the 50 milligram dose has a half-life of approximately 36 hours. So if you take it continuously, it's the microglial cell expression and the opioid growth factor axis are quote unquote permanently blocked. Diminishing the opioid receptor block pleasure derived from alcohol or narcotics was the main focus. And it was thought that, we had a treatment for alcohol and drug abuse. Well, it actually works fairly well for alcohol abuse, but not so well for drug abuse. The reason is that although you won't get high, you do go through withdrawal, and there was a large number of deaths in high opioid use patients. So naltrexone blocks the endorphin receptors. It inactivates specifically the mu and delta and epsilon opioid receptors. The blockade of the opioid growth factor receptors is what helps or enhances chronic wound healing and corneal abrasions, but unfortunately it enhances cell growth. And in the case of tumors, it actually it increases tumor growth or encourages it. Now check the low dose naltrexone now, which is about a 10% or actually less than 10% of the prescription dose, temporarily blocks the opioid growth factors. It increases the synthesis and sensitivity of the endorphins. And what happens is you get the body sort of overreacts, and we get a rebound, and we get an increase in endorphins once the low dose naltrexone wears off. So depending on the dose, from very tiny doses to what we consider low dose, and low dose is now considered 4.5 milligrams at maximum, although I'm going to show you one exception to that. We get an overabundance or an overgrowth. You'll have or overproduction of endorphins as a reaction to the temporary blockade of the opioid receptors. And there's also an anti-inflammatory component to it also. So toll-like receptor 4, four receptors when activated in injury produce pro-inflammatory cytokines. Low-dose naltrexone has a special affinity to the toll receptor 4 receptors, and it attenuates the pro-inflammatory cytokines. So it works, in two different ways so far. So here's the difference between high and low dose naltrexone. High dose naltrexone is considered 50 milligrams. Low dose is less than 5 milligrams. So high dose naltrexone, we get a continuous blockade of your endogenous opioids and metacaphalin receptors. And the low dose naltrexone, we get a temporary blockade. We also get some microglial reaction in the low dose naltrexone receptor also. High dose naltrexone will decrease endorphins. Low dose naltrexone ultimately leads to a rebound increase in endorphins. And high dose naltrexone will promote cell growth and increase tumor growth, while the low dose naltrexone is pro-inflammatory cytokine. It mediates pro-inflammatory cytokines and inhibits tumor growth. So here's a schematic of actually how it works. And it's considered two, like I have over here, two meds in one. I actually, in here, I actually had a package of certs. Those of us mature enough to remember certs was two mints in one. There was a candy mint and a breath mint. They form in the AMG people took that out. I guess that was a brand name, so we couldn't have that. So it's considered two medications in one. There's a levonaltrexone, and this is your opioid or your endorphin release. And then over here, it's in the dextro or the right-handed side, that's your microglial modifier. It inhibits the pro-inflammatory cytokines. It antagonizes toll-like receptor cytokines. And these are all the cytokines that low-dose naltrexone has properties against. So, as we've talked, many times about many different types of entities, and we've talked about the inflammatory cytokines, you can see that it covers quite a large range of them. So just for fun, I did this paper about 6 years ago on the anti-inflammatory effects of acupuncture. And, we found some papers and some studies, and it shows that, acupuncture has anti-inflammatory reactions or properties against interleukins 1B, 2, 6, 12, 17, interferon gamma, and TNF alpha. Also these neuropeptides, and it upregulates anti-inflammatory interleukins 10 and 4. So these are some of the talks I've given over the past 2 years. And I went back and I pulled out the inflammatory cytokines for each one of these entities. Remember, we did head injuries, we did post-finasteride. I did the gadolinium last spring here, and then our autism lecture. And here's the common denominator here: interleukin 6 and TGF beta 1, and you'll find them in here. That low dose naltrexone has properties against both of these, which is common to all of them, and most of all of these. So here's a brief list. There's an LDN Trust research website. There's whole conferences on this, 4-day conferences. This is just a short list of entities that have peer-reviewed papers that have been written about these entities, and you can see they're quite extensive. And I use this a lot in my practice, especially lately, and more, and that it's becoming quite a go-to for us. So, and in these entities here, it'll have allergies, mast cell activation. I just pulled this one out. So this is just skin conditions that have peer-reviewed papers using low-dose naltrexone, and this is just in the dermatology world, and you can see it's quite extensive. And again, we go back to what we're doing is, we're blocking the opioid receptors. We're diminishing the toll-like receptor 4 pro-inflammatory cytokines, and we're affecting the opioid growth factor receptor model. So we can look at psoriasis as a clinical marker for inflammation. Psoriasis is a keratinocyte hyperproliferation. It decreases skin cell turnover from 27 days to 3 to 4 days. It's associated with an increased risk of atherosclerosis, cerebrovascular accidents, coronary artery disease. Psoriasis patients on average have a 5-year shorter lifespan due to cardiovascular disease than their non-psoriasis peers. Psoriasis is an emerging risk for cardiovascular disease, and any patient with moderate to severe psoriasis should be screened for cardiovascular disease. Here are the cytokines that are involved, and again, TNF alpha, interleukins 12, 13, 17, 22, and the JAK, Janus kinases. It is a epidermal opioid system rather than hyperinnervation, and low-dose naltrexone has been safe and effective for psoriasis, including pruritus. And here's the references on that. It acts on all three of the systems that I've outlined as the mechanism of action for low-dose naltrexone. It acts on the opioid receptors, releases beta endorphin. It reduces pro-inflammatory cytokines, increases anti-inflammatory cytokines, and it regulates the opioid growth factor receptor axis. In this study, there was a 57% reduction in severe psoriasis over a 5-year period. Here's the dosing schedule. Real quickly, it's 1.5 milligrams, and we usually have to dose it in a tier step-like fashion. Some literature will say that you can do it in 7 days instead of 14. I like 14. It kind of gives the patient time to kind of get used to it. Remember, this is a compound. This is not a FDA approved dose schedule. So it has to be compounded. Some of the patients get the 50 milligram pills and water them down themselves. I don't really recommend that unless you know what you're doing. But so we start at 1.5. We make 1.5 milligram capsules or tablets. The tablets seem to have less of the side effects than the capsules, and I'll tell you what those are in a minute. For 7 to 14 days, you take 1.5, then you go to 3 milligrams or 2 1.5s for 14 days, and then three 1.5s for 14 days. I tell the patients, and I write it on the prescription, to call us between weeks 5 and 6, and then we'll work on the next dose. The cost of this, depending on where you go, can be quite reasonable. We have a couple of mail order places we use, and we can get them for about 50 to 60 cents a pill. So this regimen is 84 pills, so it's about $42 plus shipping. So it costs about $50 for the loading dose. Then we can make it into, if the patient can tolerate the 4.5 milligram, we write it 4.5 milligram tablet. We'll get them 90, and it'll be $45, and that'll last 3 months. So it's about $15 a month plus whatever the shipping is. If they're not doing well after 6 months, we actually decrease the dose to 3 milligrams and then slowly increase it by half milligram every 2 to 4 months after that. That seems to help. If there's an anxiety or depression component, we actually need to use lower doses. You're going to use lower doses with anxiety and depression. You're going to use lower doses with Hashimoto's thyroiditis. I'll get into that in a minute, and also multiple sclerosis. Those patients seem to be extremely sensitive to the effects of low-dose naltrexone. And usually our top doses here is about 3 milligrams, 3.0. And here's the dosing schedule here. I can get you them. We'll put this on the website if anybody wants it. We start at a half milligram for 14 nights, and then increase it by, we go to AM and PM for a total top dose of 1 milligram twice a day. Here's some topical solutions. I'm a purist, so I use this one. Zematop is an anti-inflammatory lipid-based carrying agent. And so we'll use naltrexone 1% in a Zematop cream. We've used this one also for itching with the psoriasis patients. Those are the two that I use the most. I also use we'll use it in some of our hair formulas, especially if there's a lot of eczema or scalp inflammation. Autoimmune disease, this is where I use it the most. Hashimoto's thyroiditis, it is a hypothyroidism as a result of thyroglobulin specific T-cell mediated thyroid tissue destruction. Graves' disease is hyperthyroidism. due to excess production of thyroid hormone induced by thyroid receptor stimulatory antibodies. I stole this from Dr. Pam Smith. She spoke to us a while ago on rheumatoid arthritis, and also, she's one of the A4M mentors, and she has 3. I put in a 4th one. So her go-to. So any autoimmune success, Dr. Burgess, if you're stuck, gluten-free diet, fix the gut, low-dose naltrexone. I threw this in. We use plant sterolins quite liberally, especially for the Hashimoto's patients. Plant sterolins are plant fats, and they actually in the bloodstream act almost like I tell the patients it's like Pac-Man. It kind of gobbles the antibodies up, and they are quite effective if they're used regularly. They don't work that quickly, but they do work. So if you have a patient, they will decrease the thyroid antibodies by about 50% per year. Usually we need to use these twice a day. Magicare is one that we use. I use Thorn. We can also use Wobazyme N. There's a lot of different Wobazymes. That's by Douglas and Pure. We like Wobazyme N, and we use that twice a day. That's a little bit weaker, but it's a little bit less expensive. And they will decrease your thyroid antibodies if you use them by, like I said, 50% per year. So on average, somebody showed up in my office today. His TPO was 154. On the Quest scale, the normal is 9. And his complaint was fatigue. He was 55 years old, and he thought he had a testosterone issue. Well, his testosterone was 750, and his free testosterone was more than adequate. So, so we like the plant sterolins a lot with any type of autoimmune issues also. And this is my go-to. These 4 subjects: gluten-free diet, and I do the Judge Judy thing. It's a yes or a no. It's not a little bit. I had a little bit here, a little bit there. I did some of this. It's either you're going to do it or you're not. Also, dairy-free and lower carb is a help. Again, fix the gut. So we do the GI-FX stool test, low-dose naltrexone. Okay, so T cells are a different type of white blood cell derived from stem cells in the bone marrow. They protect the body from infection, and they might help fight cancer. You have helper T cells and killer T cells. They come in 2 varieties: Th1, Th2. I'm going to defer to Dr. Halasso on the details on this. Healthy individuals have a greater Th1 to Th2, while injured patients have a greater Th2 to Th1, and our goal is to be balanced. We need to be like Goldilocks. The Th1 cells are responsible for killing intracellular parasites, and perpetuating autoimmune responses. Excessive pro-inflammatory responses can lead to uncontrolled tissue damage. Excess Th1 results in cellular immunity, type 1 diabetes, Crohn's disease. Interferon gamma is the main Th1 cytokine. There's a couple of chats here. I just want to make sure. Okay, I just want to make sure. All right, so nothing, we'll get them at the end. So Th2 cytokines includes interleukins 4, 5, and 13. It's associated with the promotion of IgE and eosinophilic responses in atopy. Interleukin 10 is an anti-inflammatory cytokine for the most part, and in excess, Th2 responses counter Th1 mediated microbial action. Immune dysregulation is usually a Th2 to Th1 imbalance and results in chronic illness. Here's a schematic of Th1, Th2 imbalances, and here interferon gamma, interleukin 2, TGF beta. When we have that as an overgrowth, we have in thyroid issues, we have Hashimoto's thyroiditis, and when it's interleukins 4, 5, and 13, it's Graves' disease. So these are kind of polar opposites. So in mechanisms of action of low-dose naltrexone and Hashimoto's, 2 to 3-fold increase in endorphin activity, reduction of pro-inflammatory cytokines, an increase in anti-inflammatory cytokines, and the regulation of the OGF receptor axis. Some clinical pearls: low-dose naltrexone improves T4 to T3 conversion. You need to monitor the thyroid replacement dosages every 6 to 8 weeks. It will improve your thyroid function. If you don't adjust your thyroid medication, the patients will become hyperthyroid. And we see this over and over again. So make sure that you're monitoring their thyroid function if you put them on the thyroid patients on a low dose naltrexone. We start low here, 0.5 to 1.0 milligram at bedtime. Increase it by 1 milligram every 1 to 2 weeks, a maximum of 3. There is some literature that has it dosing at 4.5. I have well over 500 Hashimoto's patients. The usual dose tolerated is 2 to 2.5 milligrams. If they're sensitive to it, particularly sensitive, you can use the liquid form, and they can be compounded at 0.1 milligram intervals. So you can put 1.1 milligram, 1.2 milligrams, and change it every 4 to 8 weeks or every 12 weeks as necessary. So we want to get as much of the LDN and as high a dose as we can with without throwing the patient into hyperthyroidism or some of the, again, I'm going to go over there's very few side effects, but there are a couple that we need to watch out for. This study, we had a reduction in pain of 57%, improved energy, reduced fatigue, and improved mood. Crohn's disease is a transmural relapsing inflammatory condition afflicting the digestive tract. Opioid signaling has long been known to affect secretion and motility in the gut and has been implicated in the inflammatory cascade of Crohn's disease. Cytokine involvement is TNF alpha, interleukin 1 beta, a decrease in interleukin 10, which is the anti-inflammatory, and interleukin 12. A 17-patient study, pilot study of patients that were intolerant to conventional therapies received 4.5 milligrams of low-dose naltrexone at bedtime. 67% of the patients treated had a remission versus 23% in 90 days. Follow-up study of 40 more patients, 4.5 milligrams of naltrexone or placebo. There was a 70-point decline in a Crohn's activity disease activity index, 200% increase in mucosal healing with colonoscopies, and just across the board improvement. At 12 weeks, there was 78% improvement in patient outcomes with naltrexone versus 28% in the placebo group. This is a little blurry. I really like this slide. This is an outfit called Cure Together, and they do surveys of the treatments of chronic diseases and rank them on the scale. These scales
Can you
here.
look that up, Cure Together?
What's that?
Cure Together.
It's called Cure Together, and they rank different types of disease of treatments of disease processes of effectiveness versus popularity. And you can see down here, here's your Pentasa, your Asacol, your cord enemas, your Imurans down here, and up here at the very top is low-dose naltrexone, and this is for Crohn's disease. Fibromyalgia is diffuse musculoskeletal pain and specific pressure points without a really diagnosable cause. In other words, I hurt, I don't know why, and nothing seems to fix it. I've seen it affects 1 to 2% of the general population, mostly women. I've seen it as high as 8 to 10% in some literature. The affected cytokines are TNF alpha, interleukin 6 and 8. The symptoms are fatigue, sleep disturbance, peripheral edema, and there's deleterious effects on thinking, concentration, and memory. And if you'll remember back to our traumatic brain injury talk with neuroinflammation, the symptoms are similar. This is the FDA approved pregabalin or Lyrica. It's an anticonvulsant. It's for diabetic peripheral neuropathic pain, post-herpetic neuralgia, fibromyalgia. Its effectiveness is hit or miss. Patients rated it on a scale of 5, and they gave it anywhere from a 3 to 3.5. Some rave about it, and there's some that have extreme side effects and kind of curse at it. Here are some of the side effects from pregabalin: sleepiness, vertigo, feeling hungover, blurred vision, dry mouth, chest tightness, weight gain, swelling of the hands and feet, bruising, bleeding, physical weakness, sudden mood changes. You know, remember, this is somebody who's got fibromyalgia, loss of concentration and memory. So not really ideal. Low-dose naltrexone, this study here of 12 women that did not have rheumatoid factors or positive ANAs or high SED rates. And the objective findings were Ashi points or tender point examination, hot and cold pain, and SED rate. 50% of the patients perceived their fibromyalgia was as improved or much improved. 10% said there was little or no change. A follow-up study, 4.5 milligrams over 22 weeks. The low-dose naltrexone acted on the neurons that created pain, fatigue, and symptoms of fibromyalgia, decreased beta endorphin production, pro-inflammatory cytokines, and it enhanced NF-kappa beta interleukin 6 to produce more pro-inflammatory cytokines. There was a decrease in it. Versus placebo, pain relief was 28.8% in the low-dose naltrexone group versus 18% in the placebo. Response rate was 33% versus 11%. Side effects were similar to placebo. Again, here's the cure together. Down here again is the FDA-approved drugs. There's Cymbalta, there's Lyrica, Savella. These are the drugs we use for fibromyalgia. And then way up here again, low-dose naltrexone. Multiple sclerosis, chronic inflammatory disease involving demyelination of the central nervous system. Mechanism of action, opioid growth factor, access deregulation, decrease in opioid growth factor prior to the onset of clinical illness, microglial activation, and oxidative and reactive oxidative stress is increased. Cytokines that are involved are TNF alpha, interferon gamma, interleukin 2, Th17, interleukins 1, 17, 22, Th17, and there's reduced interleukins 4 and interleukin 10. The low-dose naltrexone prevents the excitatory neurotoxicity of glutamate on the neuronal cells and oligodendrocytes, restores levels of opioid growth factor, reduces inducible nitric oxide synthetase activity, decreases interferon gamma, TNF alpha, inhibits glutamate transports, and reduces apoptosis of the oligodendrocytes. You need to warn these patients that they're going to get worse before they get better. And that seems to be pretty universal with low-dose naltrexone in multiple sclerosis. 60 out of 80 patients completed an 8-week study of 4.5 milligrams nightly. And there was improvements in mental components, mental health capacity, pain scale effects, perceived deficit questionnaires were improved, and beta endorphin and endorphin concentrations were increased, resulting in significant decreased spasticity. So it's my original acupuncture teacher back in Wilkes-Barre, PA, who was from Korea, would say it was good stuff. Here are cytokines for different types of cancers. Increased opioid growth factor receptor activity in cancer cells. LDN depresses this cell proliferation. Opioid growth factor suppresses cancer growth in colon, hepatocellular, and follicular thyroid carcinoma cell lines. Opioid growth factor, menenchyfalin 5 and its receptors mediate the action of LDN on the cell proliferation. Low-dose naltrexone produces rebound OGF activity and inhibits cell proliferation in vivo. In vitro studies show increases in interleukins-2, white cells, and NK cell activity, interferon gamma, and destruction of opportunistic infections and cancer cells. Low-dose naltrexone at the dose of 0.1 milligram per kilogram reduces neuroblastoma tumors in 66% in this mouse experiment, decreased tumor development 98%, and an increased survival rate of 36%. It alleviated a weight loss associated with cisplatin toxicity, and in a review of cases of pancreatic cancer treated with IV lipoic acid and low-dose naltrexone, some reported signs of cancer gone, including liver metastasis, and that was down here in 2010. Phase 2 trial of 24 patients with pancreatic cancer who failed on chemotherapy were given opioid growth factor IV, showed a threefold increase in median survival time versus untreated patients, with tumor sizes shrinking up to 62% of the patients. Here's the treatment guidelines here. Again, our 1.5 milligrams times 1 week, increase it to 4.5 milligrams. When the patients were in admission, we treated them 3 days on, 3 days off with low-dose naltrexone. Low-dose naltrexone will interfere with the activity of chemotherapy, and if you're going to, patient's going to get chemotherapy, it needs to be stopped 2 days before until 2 days after. Autism. So those of you who've heard my talk on it's autism know that there was a mention of this here. This is a picture. If you're not familiar with autistic children, this is the perfect picture here. This is Wyatt, his first day of kindergarten. Here's the teacher. Here are all the children looking at the teacher, and here's Wyatt looking away with his head down. Impaired social interactions, deficits in verbal and nonverbal communications, abnormal repetitive behavior, finger flapping. They play with objects in an inappropriate way. Etiology there's not one single etiology, but we can put it together with maternal activation, which translates to placental infections usually, or poor nutrition, microglial activation, inflammation, and cytokine storm. There's delayed language skills, an inability to initiate or sustain conversations, using their own language, lack of appropriate age-appropriate play, lack of joyful experiences, and they like being alone. This is a little graphic that I made of here's our cause, here's our effect, and then in here there's a treatment wheel too. Mechanism of action for low-dose naltrexone: cytokine inhibition, shift from Th1 to Th2, and LDN downregulates your interleukins 1, 6, and TNF alpha. It affects self-injurious behavior, hyperactivity, attention deficits, social withdrawal, agitation, and eye contact. A study with children ages 3 to 8 showed improvement with fidgeting and hyperactivity. The dose was 0.1 milligram per kilogram, increased by 0.1 milliliter or 1 milligram every 3 to 7 days to a maximum of 1 milligram per kilogram, or 4.5 milligrams as a total maximum. If the patients were more than 40 kilograms, we just did the adult dosing. Transdermally, it can be made if they won't swallow it, either in a pill or a liquid form. They can make it into a cream. You apply it at bedtime. And here are the side effects: nausea, rebound insomnia, and nightmares. So we give the low-dose naltrexone. We like to give it at bedtime. The 4.5 milligram dose will usually be effective for about 6 hours. Then it will wear off. That's where we get our rebound and our endorphins. And so the thinking is that if we give it at bedtime, that by the time you wake up in the morning, you're ready to go. You're loaded for bear. About 10% of the patients have a rebound insomnia, and they won't be able to sleep. And you'll know this right away. You'll notice in the first day or two. So we drop it back down to 6 p.m. If they still can't sleep, then we drop it down to noon. And then if at worst case scenario, or if you just want to go, we just use it in the bedtime. It is not it's not sedating, so it's not that they're going to be sleepy. It's just the thinking is that we want to get the maximum endorphin response to go at the beginning of the day. There is some nausea in a small number of patients. Usually we have them take it with some food if they get some nausea. I don't think I've ever had anybody not have to stop it because of nausea, and it usually goes away in less than a week. And then there's the books call it vivid dreams or nightmares, and about 20% of the patients do get this phenomena, and some of them like it, and they have tell me some pretty wild stories. And again, we don't usually have patients have to stop the drug because of that. Weight gain or weight loss. What we see is a decrease in conversion of T4 to T3, leading to a state of thyroid resistance. In weight gain, increase in insulin resistance. We see again in older patients lower testosterone with an increased expression of aromatase, leading to higher estrogen levels, increased leptin levels, increased appetite, and cytokines involved are interleukins-1, TNF-alpha, and interleukin-6. With weight loss, naltrexone reduces insulin resistance, increases growth hormone. Increased insulin will decrease growth hormone, decreases cravings, acts as an anti-inflammatory agent, improves sleep and sleeping patterns, and it increases total T3 levels and improves T4 to T3 conversion. And indeed, there's a FDA-approved drug, which is a combination of bupropion and low-dose naltrexone. Now, one of the contraindications for low-dose naltrexone is if the patient's on opioids. They just don't mix. Low-dose naltrexone will blunt the effect of the opioids, and we generally don't use it. We get headaches, nausea, frank opioid withdrawal symptoms. And again, 2 days before, 2 days after, if you're going to need opioids, we like to stop the low-dose naltrexone. But sometimes you get broken bones or something. If there's an emergency, we just have to kind of play along. However, there can be a way to decrease the dose of opioids with what we call ultra low dose naltrexone. So ultra low dose naltrexone is 1 to 20 micrograms. Remember, we've been talking about 1.0 or 0.5 milligrams to 4.5 milligrams. The ideal dose seems to be about 1 microgram twice a day. You have to find a compounding pharmacy that will know how to make this. If the patients are on short-term opioid doses or treatment, you can decrease the opioid doses by about 10% a week and begin them on this ultra low dose of naltrexone. If they've been on it for greater than a year or they're on greater than 50 MMEs, you need to decrease the opioids by 10% per month. And we increase the ultra low dose naltrexone as you decrease the opioids. So what we do is we usually make it in a 1 microgram dose, and we'll increase it up to usually not more than 4 or 5, because we don't usually make it into 5 or 10 microgram doses. At least I don't. A couple of topical solutions: alopecia areata, which is an autoimmune disease. We can make it in a 1% scalp solution. You can add some minoxidil 5% and also some biotin, zinc, melatonin. For topical wound cares, naltrexone facilitates closure of full thickness wounds in diabetic rats. And again, the opioid growth factor receptor pathway is the mechanism of action here. Let me go back a little bit to hair. Lately, we found a very good and pretty inexpensive genetic test for hair loss. It'll look at all the 3 major hair losses: androgenic or female pattern hair loss, which is the most common; alopecia areata, which is our autoimmune issue; and telogium effluvium, which is your metabolic issues. And so we don't really have to guess anymore. The genetic test we use is $169 wholesale. I mean, it's pretty inexpensive, and you don't have to wait a whole year to know whether you're on the right track or not. So anybody wants to know what that is, I can let you know what that is. You can prevent, it can help with keloids, burns, Sjogren's syndrome, diabetic neuropathy. You can make it into a nose spray for sinusitis. Again, any type of itis. Here's, again, I showed you this earlier. your pain or wound care creams, inflammatory creams. Here's a wash for infections. Here's one for scars. Eye drops, eye drops, nose drops, pain creams. Be careful with pain creams. Somebody got a hold of my DEA number and was ordering pain creams through the TRICARE from the VA and charging $16,000 for a tube of pain cream, and they got 4 of them. And it was going to a house in Pittsburgh, a townhouse or row house in Pittsburgh, and I don't even know how they got my name, but that was a bit of a mess. That only cost me $15,000 in lawyers' fees before they say, "Oh yeah, you had nothing to do with it." So be a little bit careful with pain creams, especially with companies that are coming to you, telling you that you can make a lot of money. Here's how we can make it into a liquid. You can titrate it by 0.1 milligram doses up to 16 milligrams. Sublingual doses, you can make them into capsules. Tablets you can store them for easier titration. Tablets seem to have, compounded tablets have less of the side effects than the capsules. And you can, lotions and creams. Here's a summary of the dosing guidelines. Basically, the Hashimoto's, we start at 0.5 to 0.1 to 1.0, multiple sclerosis 1.0, all of the rest except gynecological cases, that's the exception that I told you about. We use a little bit higher dose, 1.5 milligrams. Every week we increase it by 1 pill to a maximum of 4.5 for most cases. Multiple sclerosis and Hashimoto's 3.0 milligrams. The GYN cases start at 2.25, and we can increase that to 9 milligrams. They seem to need a little bit higher dose than that, than the others. Some other dosing tips. Again, I told you this already, 1 hour before bedtime. If they have insomnia, drop it back to 6 p.m. If that doesn't work, drop it back to noon. Here's a dosing schedule if you have for allergies, autoimmune issues, cancers, chronic fatigue for children, chronic pain. We went through all of these over the last hour. This is just a summary. Here are the side effects: insomnia, about 10%, vivid dreams, 23%. You can start with lower doses or earlier in the day. Usually it's self-limiting, and some nausea. That's pretty clean as far as drugs are concerned. When you get a package insert, it'll say liver and kidney toxicity, but usually those are doses at 300 milligrams. We're talking about 4.5 milligrams maximum. Contraindications in the package insert is acute hepatitis, liver failure, alcohol or opioid ingestion, or organ transplants. LDN does seem to interfere with any rejection drugs. The pros for low-dose naltrexone: increased sense of well-being, increased energy, self-confidence, muscle strength, increased sex drive. The cons: you can have some mood swings, mild body aches, mild disorientation, sore joints, thinning hair, ulcers, difficulty sleeping. This is all in the package insert for naltrexone. Quite frankly, other than the 3 that I told you about, I really don't see any other side effects. The insomnia we do see once in a while, nausea occasionally, and the vivid dreams, we do have a few patients tell us that. Here are the cytokines that are affected, that LDN is effective against, and here are the some of the disease entities that we talked about for the past hour. Here's my little medical acupuncture. Some natural remedies that mimic low-dose naltrexone: glutathione, vitamin D, selenium, zinc, iodine. These are all T-cell enhancers. Anti-inflammatories are, and we all know this, right? Curcumin, boswellia, green tea extract, skullcap, quercetin, bromelain. I have here all the references in order in case you need them, because I'm very sensitive to there's no evidence for fill in the blank. And that is my spiel. So anybody have any questions? I know there were some things in the chat. Let me see how I can pull that up again. And hope that wasn't too bad. For being on the fly here. How do I get? There we go. Okay, so
Well,
we got-
great job. I just want to add something here, very important, Dr. William. I mean, I will refrain giving low dose naltrexone for allergy and cancer, but I will give it for all other diseases that you mentioned, just because you said it's shifting to TH1.
Right. Well, I
from
told you
TH2 to-
I was going to leave that. I'm going to leave that up to
Right.
you. You're
just
the pro
because
on
we
that.
have a discussion with Dr. Cheryl about it as well.
Right.
And for cancer cases, and I think we don't have that much of evidence, or there's controversial there. There's some articles it says it does have anti-cancer effect, well, possibly intrinsic, but I'm worried about the shifting from TH1 to TH2, because this will favor the cancer growth, and also for
Dr. Halasa,
allergies.
Dr.
Right.
Halasa, this is
I'm
Dr.
with you.
Patel.
Go
Can I
ahead.
interject
Yes.
for 1 minute?
Yeah, sure. Go ahead.
Okay. Dr. Bihari from New York City, he
Mhm.
did a lot of work on cancer patients,
Right.
and as well as there was another presentation we had, and both of them were the followers of alpha lipoic acid and also the low dose naltrexone. So it may be the 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 mechanism might have, you may have to check that, because low dose naltrexone, just by using low dose naltrexone, Dr. Bahari was treating the pancreatic cancer just by
Right.
using low dose naltrexone. So you may want to look into it little bit more details before we suggest that do not use it.
I didn't
No,
suggest not
I
using
agree
it.
with you.
I didn't suggest not using. In fact, we had I had 3 or 4 slides on it, for cancer. It inhibits the toll-like receptor 4 mediated pro-inflammatory cytokines and inhibits cell growth. That's why the low dose naltrexone is effective. It's the high dose
Yes.
naltrexone that
Yes,
promotes.
you were right. But Dr. Halasa was making a comment that
Okay.
he
Yeah,
would be
my
very
comment is
careful.
not for sure. What I'm just saying is that if the low dose naltrexone shift from TH1 to TH2, you may have some intrinsic anti-cancer effect, like CBD works in both direction. But my concern is that if it's shifting to TH2, this will favor the cancer growth. But again, naltrexone may have intrinsic anti-cancer effect, which is maybe that's the reason it's working, and maybe that intrinsic anti-cancer effect overweight the polarization to TH2. So I'm
It
just
may have
saying, is this
anti-inflammatory
a
effect,
suggestion?
too.
Yeah,
Right.
just there's a big question mark there.
All right. Yeah. My consensus is, overall take home is anything with an itis, anything that's growing that you don't want to grow, this should be effective against. So that would
Thank you,
include
Brad.
cancer cells. So other questions, can it be used as maintenance in healthy individuals? Yes. What conditions are starting at the lower doses? Hashimoto's thyroiditis, multiple sclerosis, and an anxiety depression.
Even in patients with the Lyme disease, I have used that, and like you just said, that any itis you use it, but what I have noticed that in these patients, you start very low dose. If you start even at 1 and 2 milligram, patient may experience weird dreams.
Right, exactly. Is there literature about LDN and interaction with chemotherapy? I think I have some references in here somewhere on this page here. If not, I'll get them for you. Okay. The hair test is by an outfit called GX Sciences. It's a swab. It's a genetic swab. It comes with a little swab. You swab the inside of the cheek 20 times on each side. I put it in the container. Off it goes, and then we get 2 weeks. We get back a report. It's quite extensive. But the best part of it is at the very end, it will give us actually a topical formula to use specifically for that patient, and also an oral formula. Dr. Nario says that RGCC Greek cancer test uses LDN against cancer cells. So, should you use it if you are using herpessin for cancer or a monoclonal antibody for COVID? That answer I do not know. So, anybody else has an answer for that? I will go find the answer. But sorry, Dr. Hortel, I don't know. So, any other questions, comments?
I have a question.
Yep.
This is Marie. I saw Parkinson's on your list, but you didn't talk about it. Have you treated any Parkinson's patients with it?
I think one or two. We use a lot of glutathione for them, IV. We have them usually come in 3 times a week. We will use this again if it falls into one of those other categories. I like using low dose naltrexone actually as a second line for a lot of these patients. It's something that I have that we have it in our back pocket in case things aren't working out so well.
There's a huge gut brain, connection with Parkinson's, right. So I can see why it might do something.
So again, gluten-free diet, fix the gut, low dose naltrexone, right? That's your go-to. Right. Even Dr. Burgess can remember that one.
Remember that.
if he's still here. I don't know if he's still here or not. So, any other questions? Again, I'm sorry that the video didn't work out. Our speaker, we'll have him probably at the end of December. I think next week we have, I think it's Kathleen O'Neill Smith, who is one of our, limelight folks. A4M is next week also, so we'll be busy with that. So yes, we have Kathleen O'Neill Smith next week, and I'm also working on CME credits for these lectures. So stay tuned. We're trying to work out a way to be able to do all of the back end stuff automatically, so you folks can get some credits for this, which would be a big help. I mean, there'd be a small cost to it, like $5 to $10, if you wanted credit for it. But the real holdup is they want a lot of paperwork, and since I'm sort of it, I don't really have time to do it all. I can if you give me a minute, I can get you the YouTube link. I'll put it in the chat for the video, our sort of failed video here. So Dr. Halasso, take over for a minute here, talk amongst yourselves. I'll be back in a minute, okay? Okay, here it is. So to everyone, this is the YouTube video link for Dr. McCullough's talk that we couldn't hear on us. So there it is. Okay. Okay. Any questions about anything? About anything? I hope that was okay for a sort of an impromptu. I wasn't planning on this, but somebody's got to step up, right, Dr. Burgess? You're next. You're next up.
Sure, that was pretty intense, Bill.
So, well, thank you all. And if you did not get, let me know if you did not get. I sent out this morning. I sent out the first warning shot about our program in Las Vegas, March 25th to 27th. It should have been around 7 a.m. Pacific time, 10 o'clock 10 a.m. Eastern time. If you didn't get it, let me know, and I'll make sure we'll find out why So get your friends, get your colleagues, get your poodles and your golden retrievers. It's a little bit more expensive where we're going now than we're used to in Reno, but I think it's going to be worthwhile. So we have some old speakers, we have some new speakers, and I think we're going to have a pretty good show. Anybody have, again, any questions? Anybody, whoever wants to present here, please let me know. If not, I'm going to let you go early. So you see Dr. McCullough here holding his head. So thank you all for listening. I hope that was helpful. If you need to know any more, you go to LDN Research Trust. Is a website that is just packed full of information. They hold 4-day conferences on low dose naltrexone. I just kind of scratched the surface. So, okay, and thank you, Sylvia, for being around. Questions, comments, complaints? If not, we'll see you next week. We got Dr. O'Neill Smith. She's one of the heavy hitters in A4M, the integrative whatever that other outfit is, and AMMG. So we've had her before. Okay. I'll have this up, at some time. Yeah, it'll be on our website. Sometimes it takes me a day or two, or if something else is going on, I usually get it up by the end of the week at the latest. So, okay, if that's it.
Thank you, Bill. Great job.
Thank you all.
Thanks, Bill.
For
Wonderful
thank you.
job, Bill.
Bill. Thank you.
Yeah, excellent.
Okay,
Thank
thank
you.
you all for being
Yes.
here. And we'll see you again next week, same time, same station. Okay.
Be
Thanks.
here.
Thank you.
And
Thank you.
how do I get out of here, John? Okay, there we go.